I want to say thanks to all the speakers and also to our sponsors. Without them, this would be hard to pull off. So, and I notice everybody mingling out there with the sponsors. So that if you continue to do that, talk to them, see what they've got to offer during our networking breaks, that would be great. So, with that, our first session of the day is entitled Risk Assessment: Meet Your Facility's Needs and Prepare for an OCR Audit. Just a brief description: a risk assessment is the basis of good and effective privacy and security policy, and if a facility wants to comply with HIPAA and HITECH, it must conduct a thorough risk assessment and ongoing security risk analysis. As with many things, that's easier said than done. It can be expensive, and many healthcare facilities lack the expertise to conduct one. In this session, we'll hear from two IT leaders who have successfully navigated the risk assessments. This session will be moderated by Chris Apgar. Chris is the president and CIO of Apgar and Associates. He has more than 13 years of experience in assisting healthcare organizations comply with HIPAA, HITECH, and other privacy and security safeguards. And our panelists include Ed Ricks. Ed is the president of Information Services and the CIO of Beaufort Memorial Hospital in Beaufort, South Carolina. Ed has more than 20 years of healthcare information systems experience, with the last 10 at the senior level. He belongs to HIMSS and Chime, and in 2011, Computer World magazine selected Ed as a premier 100 IT leader. Also, in 2011, Ed's team was rated the #4 medium-sized hospital in Healthcare IT News' Where to Work Best Hospital IT Departments. So Ed's facility, Ed and Sharon will talk a little bit about their individual facilities, but I think Beaufort has about 197 beds. Sharon Finney, on the other hand, she's the Corporate Data Security Officer for Adventist Health System. At Adventist, Sharon sets the data security strategy to ensure the confidentiality, integrity, and availability of the organization's information assets. And Adventist has 43 campuses, 55,000 employees, and more than 7,700 licensed beds. So we'll have an interesting perspective on risk assessment from both Sharon and Ed. So Sharon, Ed, and Chris, come on up.
Good morning, everybody. I'd like to sort of relay a story of this morning. This morning I got up. I have to have my coffee in the morning. Remember the commercial? I haven't had my coffee. Don't talk to me. So I put the little cup in the coffee maker, and I pressed it and turned it on, and nothing happened. So I called the front desk. This is my contingency plan, and I said, it doesn't work. And they said, well, can we send an engineer up? It's like, I'm in my bathrobe. I don't want an engineer. I just want coffee. And they said, oh, okay, we'll send you complimentary coffee. So that started my day. It actually was a good thing when that coffee arrived. So hopefully everybody is awake, and because I think this is an exciting topic that is pertinent, especially in the area of meaningful use. And one of the things about it is I hear frequently that, oh, we have meaningful use now. We have to do a risk analysis, and forgetting about the fact that that was required since April of 2005. So my intro is more to say, what do I see out there? When I'm looking out there, when I'm working with clients from the small physician practice all the way up to multi-state health plans, healthcare delivery systems, and so forth, is I find sort of this variety. Nobody really is on the same page. It ranges from, I don't know what to do and I'm not going to do it, to I'm going to do it, but I'm only going to look at my EHR because, hey, this is meaningful use, to I'll just look at my technical environment, to the bigger picture of, hey, maybe I should look at my whole organization and look at risks all over the place, not because there's a regulation that says so, but because I want to be prepared for those patients. So it runs the gamut, and I also run into entities that they don't necessarily come right out and say it, but they call and say, I tested the meaningful use, didn't do a risk analysis, can you come tomorrow and do it? And there are also, one of the other things I find is there's a plethora of tools out there on the market. Vendors like to offer tools. What I found is it's sort of the garbage in, garbage out. If you don't know how to use the tool, if you don't know what a risk analysis means, you can put lots of information into those, but what you get out the other end really doesn't help you a whole lot. So I think this for me is going to be an interesting topic that I want to listen to, how we have a smaller organization, we have a very large organization, how they've dealt with risks in their own organizations, and then I'll be moderating questions after that. So with that, I would like to introduce Sharon and Ed.
So we are spread across 10 states, so that makes some challenge of performing a risk assessment interesting. We run 3 main divisions, so I have 3 IT groups with 3 completely separate data centers, 3 disaster recovery sites. We run about 15,000 physician and office staff that access our systems across that 10-state area. We are also heavily involved in research projects around the world. And we have our own college and university of health sciences that provides 4-year bachelor's degrees in nursing and radiology tech training programs, et cetera, that also sits on one of our campuses. And we also are our own health insurance company. So there is not a business that we do not get involved in the legal and or regulatory requirements around privacy and security. As you guys well know, I mean, healthcare organizations aren't one business, they're 50 under one building. And so it does make it very interesting from the aspect of performing risk assessments. I think that my sort of position on risk assessments is I don't really do risk assessments. I assess risk, and there's a difference. Because assessing risk is something that you do every single day. It's incorporated into everything that you do as a security professional, versus going in and saying, I'm going to have a risk assessment done. That's a one-time thing. It sounds like it has a beginning and an end, and it doesn't. So, and particularly in an organization our size, I could bring Chris in and he could spend the rest of his life 24/7 trying to do one risk assessment of our entire environment. And frankly, it would do only 2 things for me. First, it lets me check a box that says I did one, and it would generate more work than we could feasibly get done before I would have to come back and do the next risk assessment. So the way that I build my program is that we do continual risk assessment in everything that we do, and I'm slowly educating all of our IT groups to integrate that into everything they do, from the contracting and buying process of technology all the way through to the deployment, design, build. There's risk assessment processes built into each of those functions so that we can just honestly keep up with the pace. So with that, I'll turn it over and let.
All right, great.
Thank you, Sharon.
So I almost got dizzy just listening to Sharon talk about how big the scale is for what their organization, and we're definitely different. One thing, I guess, in full disclosure, I noticed that my title was a little bit wrong, so I'm not the president of Information Services. There was no mission of the vice part, but thank you. It sounded really cool, so I might change my business cards, get out a Sharpie and cross that off or something. But we're the perfect sweet spot for a community hospital. We're about a 200-bed hospital, the sole hospital in our county, and so we do provide services for a lot of people. Fairly advanced, I think, partly because of the area we live in, South Carolina. It's a great retirement area, so a lot of people retire and move down from this area, Boston, the Northeast, and they have these high expectations of health care, which is fantastic, so it keeps us kind of progressing and moving forward. But we just don't have that depth, and so I think you're right when you said that, a risk assessment doesn't necessarily have a beginning and an end, and I think it does have an end. It's the day that you get fired because you're not paying attention to what's going on, regardless of how big you are. And so, when we did this and approached it, I think our goal was to be very practical, and we have to do that with a lot of things, and not get lost in how big the scale could be for a project like this, but actually just come up with a process that's methodical and made sense for us, implement that, get the assessment, and then ongoing continually manage that risk. And it took us a while to do that and figure out how to do it right, I think. And again, I think just because we don't have the depth of knowledge, I brought some people in to help us with that, because I want to make sure that we're not missing anything as we go through this, but then develop our program of security committee, and how do we roll that up to our board, and how does that work, and get the buy-in from the board down, and get the physicians on staff to also be engaged in the process. And I think we've been pretty successful with it so far, and so I think I'd go from that, and we can go back and forth, Chris, if you'd like.
I'll ask a question to both of you. Ed, you just mentioned getting the board's buy-in. What is your strategy when dealing with the senior level of the organization, such as the board of directors, to get them to buy into the fact that there is this process that's an ongoing that you need to pay for, because in the end it's going to save you money? So I think people would be interested in how you sell it to the senior level.
You know, and we've always had a pretty well-managed risk management program in the hospital that focused more on the healthcare side of what's going on, not necessarily on some of the business aspects of what we do. So I don't think the concept was foreign. And we have a pretty engaged board, which is great, some pretty talented people. And so they definitely understand if I bring these things forward, the importance and relevance of it. And really wasn't difficult at all. You know, they definitely understood meaningful use and what that might mean to us, and we were sort of at the point where we felt as if we were doing all the right things from implementing IT within our environment for the past number of years anyhow. And it wasn't about the IT projects, and it wasn't about checking a box for anything. It was about trying to improve the quality of care that we deliver and patient safety. And so we just got lucky that meaningful use came out about the time that we were just kind of hitting the apex of all those things. And even though some of the requirements were silly, I think most of them are actually pretty good, and I think with the right intent. So even though we were doing some security risk management, because as you mentioned, it's sort of been around for a while, we didn't have a well-developed program, and I knew that. And so that just gave us an opportunity to, I guess, bring it forward to the board, work on developing a real program, and it's actually been very well received.
Great.
At Adventist, fortunately, I've been there almost 5 years. It'll be 5 years in March. And when I came there, they have a very well-established governance process for how their boards are structured, both at the corporate level all the way down to the individual facility level. So that was great because I had a structure I could already navigate to start to communicate what we needed to do. Now, when I arrived, they were doing sort of what they called a risk assessment, which was really more of an audit than it was really truly a risk assessment. It was going out and taking the HIPAA security rule and saying, do we do this? Do we do this? Do we do this? Do we do this? And that's not really a risk assessment. So I began the process of starting to communicate to the board why we needed to transform this program into less of an audit style to more of a true risk assessment by communicating it to them in terms they could understand, which is not, firewalls and, technical security controls or IT controls, but talking to them about the real risk of the information that we were trying to protect and starting to equate that to them in terms that they could understand. I think it's hard for people to conceptualize data as an asset because you can't really put your finger on it. You can't, wrap it up in a box and say, here's your data, here's the risk that you have. And so one of the first things I did was to get them to understand how much data we have was, I had to go find that out. Exactly how much data do we have? What I found out is nobody really actually knew the answer to that question. How much data do we have? And so when I got done, I was able to break our data down into some categories, and I said, okay, we maintain 18.5 million individual patient records in our systems. Multiply that number times 100. That is the minimum cost in the event that we have a catastrophic compromise and all of that data is compromised. If it is a major compromise, multiply it by about 250 and then just put a little tick on the end that says up from there. And when you equate it to them like that in a value they can understand, they started to grasp why we need to dedicate resources to that. And at that point, what I started to do was I leveraged the other organizations that were already in place. As you'd stated, our risk management program and our compliance programs on the patient safety side, the compliance side of the house were very well established and well understood. So I took those as a model to start to build my program sort of around that because it was something they had already bought into. Secondly was I engaged other departments that don't normally engage with security unless, of course, there's a problem and they need to throw something over the wall and say, go fix that, was to bring in legal, human resources, our compliance team. I made sure that we have liaisons at every facility, both on the compliance as well as the technology side, so that we've got touch points on the ground in each facility that we have that I can utilize to understand how that particular business operates and what their particular risks may be. So it's really about you knowing your organization and understanding who you need to engage to sort of build that support group around you to help you do this. It's not something you can do in a silo at all.
Thank you. Next question. There are probably people in this room that are on this side of the spectrum where they're sort of getting started and trying to figure it out. To those that have done it, what are the tools, whether they are things that you made in-house or you created in-house, that you would say would be effective in assisting an organization to run that whole process around meaningful use, which is the risk analysis, mitigation, and then risk management?
Yeah, we ended up with a kind of a hybrid tool between the consulting firm that I used and what we developed in-house. And in fact, I've given it to Mike. I think he's going to make it available, or a sort of a shell of it available for people who want to see it. Very simple. Again, I'm trying to become practical for what we do. So it just takes all the ISO rules, maps it essentially to the HIPAA rules, and then maps that. There's a crosswalk to all of our internal policies so that as we make changes, we know where we're updating what we've done. And then for each one of those things, if we have any deficiencies or try to calculate, we do calculate the risk for each thing, the potential of an event happening because of that and how bad that event would be if it did happen. And so then what possible mitigating steps we could take to lower the risk. In most cases, you can't eliminate risk, although as part of this process, I've sort of learned my two new favorite words are safe harbor. And so we've done a lot of things to sort of help us that. We don't have any PCs in our hospital anymore, so it's all zero client devices. There's no drives, there's no data stored. Every individual authenticates, with a RFID and a password to our systems. And so we eliminate as much risk as we can from that way. But then in our tool, as we look at this, so then we can map what are our biggest risks or where are the biggest gains if we take these mitigating steps, because we can only afford either in resources of time or money to do some things, not everything necessarily. So you understand what your risks are, you know what the changes could be, and that's what we work towards. And so that's what I report to the board. And then as we keep moving through that, things shift and change on that. But it's been a really nice tool, and it's easy, it's very visual, it's very easy to follow, and I think it helps us cover all the bases.
For me, when I came to Adventist 5 years ago, it was very important for me to learn our organization, not only from a sort of CISO perspective, but I needed to understand the technical architecture, and I came up technical. So I was a database administrator and a Unix system administrator, and so I understand firewalls, and I can talk to technical people. And so I started the process of doing first an information gathering mission to say, let me know my environment. So I wanted to know my technical architecture, how my networks are laid out, to see where things sit. And then what I did from there, once I understood technically how our organization was structured, then I could start to see how data would move between the organizations. And then I went and I said, okay, now let me learn about our people, because there's three things that create risk in your business: people, process, technology. That's it, okay? Those are the three things that make your business run, whether it's a hospital or any other business. So people, processes, and technology create risk. And I needed to understand the people, I needed to understand our critical business processes, and I needed to understand the technology that drives both of those. Because it's at break points or joints in those things where they intersect where you get risk. And wherever, as you said, where you can take those break points out by utilizing RFID or different authentication mechanisms where they've got no ability to store data locally, you start to take out risk points in sort of your design. And then I created an interview questionnaire. So we have an interview questionnaire for people to understand how they handle data, how they use systems, how they interface in the environment. And then also for the processes and the technology similar to what you've created. Mine are structured to be done in a very decentralized way, because I have to send mine all the way out to a facility level 3 data centers, so I break it apart into some manageable chunks and the questionnaires and things are focused. Are they more towards business people or are they more towards technology people? Because you can't talk to those two groups the same way or ask them the same types of questions because they don't speak the same language. We utilize a tool from Semantic called Control and Compliance Suite. We use their Response Assessment Manager product. Basically, it's a survey tool, okay? It allows us to automate those questionnaires, which, when you've got 55,000 people, and I communicate through our risk assessment process with probably about 7,000 people a year. There's no way me and my team could do that manually. So we have these questionnaires and things set up to go out to them automatically. They come back to our tool, they fill out the questionnaires, we get the information in, we review it, determine, and then we use that information that comes in to know now where do we need to go deep dive in an audit and really dig into the security controls of our electronic health record or our physician EMR or a particular biomedical system that's come into the environment. That will tell us where to target those deep dive risks or deep dive audits, because what comes out of the audit is the detail that you need to drive the change. And driving change in an organization the size of Adventist is a very long, very slow, very painful process because it is very big. It's like moving a really big ship. Depending on the size of the change that you want to make. But it's definitely, if I had any advice for anybody, it's break it down into small, manageable pieces. And every one of these you do will tell you more information that will make it better every time. It's an iterative process.
Thank you. This is a sort of a rhetorical question because nobody wants to talk about being audited. But if you receive that letter, whether it's from CMS for meaningful use or you receive that from KPMG for an OCR audit, what would you recommend as far as being able to prepare for that, knowing that that's not the only thing and that's actually not even a primary thing for risk analysis? But if you got that letter, what would you do? How would you respond to the Office of Civil Rights or CMS?
Take that one.
Probably the first thing is you recognize you're getting much closer to that end that we were talking about before. But I think what's important is that you're demonstrating that this is something that you're managing on an ongoing basis. And so nobody's going to be perfect. Things are going to happen regardless of how tight you think your controls are. But it's understanding what the risks are, showing that you're trying to make some improvement, as that improvement changes over time. And so I think that part of what's going to help us, hopefully, if we ever get to that point, is that we do have a tool in place that's helping us manage that over time, showing that difference. The minutes from that are in our board minutes, so that we've shown it from an organizational level, from a governance level, all the way on down to the medical staff is seeing this in the rest of the hospital. So as much as anything else, nobody wants it, but I think you've got to become prepared that way, that you've got to actually do the work, do the steps, still keep it practical. You can't become theoretical, and possibly I think us being a little bit smaller helps us be more nimble than what Sharon has spoken about. And so I think that we've made a bigger change in some of those things because we can a little bit more quickly and easily, but we also aren't quite as sophisticated probably in some things, so it's more difficult, or maybe the capital is different for us to come across than it may be a bigger organization. But as far as we're concerned, we are keeping a good log of what we're doing. We're making some change. We've created this culture that's a little bit different than it was a few years ago, and I think that helps position us. And same thing, some of the tools that you have, so our tools for that risk assessment are, we're just implementing a new tool now for doing a lot of our data analysis and incident response that we would handle, and that's going to combine our privacy and security. And so I'm looking forward to that being a little bit cleaner also.
At Adventist, you can imagine, for us, it's with 44 hospitals and 350 physician practices, the likelihood that one of our entities is going to win that CUPE prize is pretty likely. Fortunately, we were not a part of the last series of the privacy, security, and breach notification audits performed by KPMG. But we have subsequently been involved in the recent OIG questionnaires that have gone out. And, they're going to want to see, well, this is what we did, this is how we remediated it, so that they know that you have a good process and that you give attention to the privacy and security of the patient's information that we're charged with to store. And I think that is the key, is to be able to, not to try to scramble and, put stuff together and all of that. You've got to start the process way before you get that letter and make sure you have everything you do documented. And then when they come, you just provide them with all of your documentation and you put them in a room and do that. Now, if you're a smaller facility, I'm very fortunate. I have a fairly sizable team that I have access to. But if you're a smaller facility, I would say definitely look to outside resources, like consulting resources that can potentially be there with you when the audit is occurring, or to come in, and help you prepare for that. Don't hesitate to reach out to outside resources that know and understand this process to help you get prepared for it, if you just don't have the people to dedicate. Because, the last meaningful use audit we did, we pulled 16 people full-time for 10 days to get prepared for that for one of our larger facilities. So it's not insignificant, the amount of time and resource that it takes to be well prepared for that. Yeah. But they came in, they stayed 2 days, and they left, which was ideal for us. So.
Yes, I've firsthand seen how painful they can be if you don't have everything together and you're prepared for it. So it's a good point. And what I'd like to do now is open it up for the audience to ask questions of Sharon and Ed. So if you have a question, we have mics out there. If nobody goes to a mic, I'll ask another question. Looks like we have a question. Thank you.
Thank you. Could you explain a little bit more what you mean by a meaningful use audit? I don't see it in any of the regs, and so.
You want to take it? Okay.
Yeah, because we're one of the lucky few who also have gone through one.
Yes.
And I think if you attested in fiscal year 11, they are randomly auditing, although the random seems to be an awful lot of people from what I'm hearing. I think they're just going through the list alphabetically. And just to make sure that you've got the documentation to support what you attested to. We've done this via email and electronically so far, and I suspect that's probably where it will end if everything looks appropriate. But it's the same thing. Make sure that you've got the documentation for everything you attested to. A component of that is the risk assessment and the program that you've developed. And so they wanted proof of that program. They wanted proof that we did this prior to the end of our reporting period, which, is what it's what cracks me up, what Chris was saying when he first got up there, that, he has customers say, all right, we already attested, now can you help us do this? And you attested that you did it already. And someone may ask you to validate that down the road. So, I'll cheat on a lot of things, but that was just one of them I wasn't really willing to risk when I clicked that button, because I don't really think I'd look good in one of the orange jumpsuits, So it was stressful. Our 16 people was me and one of my analysts going through all of our data and everything that we'd accumulated and trying to respond to the request for information.
Yeah, and it's, as far as I know, at least the individuals I've talked to, is that every organization that received meaningful use funding will eventually be asked to provide evidence that their attestation was true and correct. That is just something that the OCR, Department of Health and Human Services, is doing to ensure that, because no evidence was required when you attested. When you performed your attestment, it was just, yes, we're doing this, yes, we've met that, yes, we've met this. It was basically a checklist approach. And in order to facilitate faster processing of the funding, and that they did that very intentionally with the intent that they would come back and validate that you actually are implementing to the degree that you have attested that you're implementing to. When we went through meaningful use, we were very methodical in how we documented everything that we did for attestation. So all of the quality measures, whether they were core or menu items, the menu items that we selected, how we met them, we documented the changes that we had to make to meet them. We have stored and filed all that by facility, so that as each of our facilities attested, we have a package of information that's pre-prepared in case of an audit. So when the individuals came in or sent the audit letter request, that was the first thing we did. We bundled up that package and we sent that to them and said, here's our documentation. And they scheduled the on-site visit. They wanted to look at our EHR. They wanted to do a walkthrough. They were, all of these things that they wanted to accomplish while they were on site to further validate. And that's why it took the 16 people. But it went much smoother for us because we had all of our documentation in order and were able to just send them a package of information. The auditor that came in to do ours said that there were hospitals and physician practices that he went to where they had no documentation of what they had done for meaningful use, no documentation at all.
Thanks. Gentleman back there?
You indicated that there are 350 private practices associated with your system. Can you talk about the process of implementation of a risk assessment, the challenges that you met in trying to implement the risk assessment and risk mitigation in the private practice setting as opposed to in the hospital setting?
Yes, those are two very distinctly different processes, what you do in a risk assessment in a hospital facility versus what you do in a physician practice. Now, the one benefit that I have around our physician practices is they all run on a central EMR application. So they do not manage their own IT. Each practice doesn't have its own EMR sitting in it. So that in some ways greatly simplified my risk assessment that goes out to the actual practice because they don't manage the technology, they don't manage the IT controls associated with that. What I'm assessing at the physician practice layer is their general knowledge and understanding how they handle the devices, how they handle paper documents, how they would do notifications. Do they have someone that is assigned as the liaison? So we made sure we got all of those. More administrative controls were applicable to our physician practices more so than technical controls. So we focused our risk assessment on that. We used that survey tool that I spoke of to build sort of a mini risk assessment survey that goes out to our practice managers. Our practice managers complete that survey, and then there's an entire set of remediation steps depending on how they respond. The challenges were in that is first, just understanding who to talk to in the practice was a challenge to get that list together. Secondly, really understanding how to ask them the questions in a way they understood. Because you can't say, do you perform a risk assessment? Do you do risk analysis? You can't ask a practice manager that question. So we had to really sit down and work and structure the questions in ways that they would understand and that would give us the answers back. And I've promised Chris that I will share those questionnaires with the group and that he can post them because there's nothing magical about them. They're all very generic.
Ed, do you have anything to add?
Again, scale is a little bit different, so we also do employ some providers now, and we've got about 30 providers in 8 practices. And we did something very similar, actually, to that. And the same thing, we have a centrally located EMR for those practices that we actually maintain and support from within the hospital, so that helps a little bit, but there's still a lot of people process things that happen a little bit individually at each practice. And we did not have each practice a test for meaningful use in 11. They just weren't at that point. Depending on when we acquired the practice, is essentially what it broke down to.
Yes, I'm Lucy Thompson, Chair of the American Bar Association Science and Technology Law Section. I wondered if you were familiar with the NISC risk assessment tool that they released last year, and it's free to providers, and whether you've considered using it, and do you know whether any of your colleagues use it?
If you're talking about HIST, the HIST tool, yes.
Yes.
It is loaded on my laptop right now as we speak. I utilize that more for my own purposes, very similar to the way I use a lot of the NIST tools as a reference or a framework. A lot of the questions that I ask, I got from that tool. Because the tool itself is really not structured for me to hand it over to a physician practice or something like that, but it is a great go-to resource to help you develop things within the organization. And then I always use it as a checkpoint to go back to say, okay, have I covered these things? You know, have I, in some way within my organization? So it has been of a great value from that.
And I would add, I think that I was not familiar with that. And again, I'm not a security expert like these folks, so they sort of lived in that world. Probably more qualified to talk to you about fantasy football, to be honest. But so we ended up with a tool that the vendor that we partnered with had developed originally, and we sort of made a hybrid model from that. But I've seen it since then, actually, after talking with Sharon and Mike about this presentation. And I agree, if there's some way to market that better, that is very useful, and I think that a lot of utility for people.
Thanks.
Yesterday, we were talking about or hearing about mobile workers and the lack of protection therein. Big organization, small organization, can you all address how you assess and then remediate, manage that? Thanks.
Want me to go
Okay.
first?
Yeah, you can go first.
All right,
This
I'll
one,
warm him up
this
on
one
this
may
one.
make me fall out of my chair.
You know, it's funny because we all recognized probably a few years ago that we had a lot of mobile technology coming into our organization, or not even coming into our organization, but connecting to our organization in one fashion or another. With the EMRs are a little bit more mobile and portable now, and email or whatever the case may be, texting. And so we were looking at some ways to manage that a few years ago, and it's really funny. I've talked to a few CIOs then and said, you know, we don't have a problem with texting in our organization. We have a policy. It's great. But you know that your clinicians and providers are texting, and so that was really one of the things we wanted to get our arms around. I think that inherently clinicians want to do the right thing if they understand what it is and it doesn't detract from their workflow. They're very crafty at becoming efficient. And here we're throwing technology at them, asking them to do CPOE or some online documentation and change the way they practice. We've got to make sure that their workflow doesn't change any more than necessary, and for sure no taking away value from what they do. And so I think it's incumbent on us to find the tools to help make that easier and secure. And given the choice, they'll do the right thing. I know the folks yesterday afternoon mentioned that, you know, there's also communication with their patients. And, you know, there's really no good way to have that become securely over texting, and that's possibly true. You know, we're going to use our patient portal for that communication as much as possible. Understand there's still a risk out there. I mean, we just have to know what it is. From mobile devices, that's another challenge, and we're looking at different ways. We haven't done anything really well yet other than know that we've got some issues with the devices. There is some really cool technologies coming out. We do a lot of VMware, so we virtualize all our desktops, and there's some pretty cool stuff with VMware now for phones, so that you can actually have your personal phone and your work phone, and the work phone's completely software, and people don't know the difference until we turn it off, and they no longer have that, but their personal phone still works on one physical device, and some things along those lines.
This is, so first I'll preface this statement by saying you cannot secure against ignorance or intention, okay? So there will always be a risk. You cannot take the human component out of the equation. So if you have someone who does not understand or know, or is ignorant of what they need to do, you cannot, there aren't enough security protocols that you can put in place to take that out of the equation, nor can you secure completely against someone who wishes to be intentional in what they do. Similar to you, we had a policy that says don't do this and don't do that, and don't do this and don't do that. And nobody knew the policy existed, and we found through a risk assessment that everybody was doing those things. So my position on mobility is that there will be a set of devices, mobile devices, that we will own and operate and control in the same probably traditional ways that we've owned devices up until now. And those will be corporately controlled, corporately locked down with all of our policies. For that mobile workforce, like our physicians coming into our facility, what we've started to do is add layers of network segmentation, where we are providing areas where they can attach to the network, where we can wrap some controls around the attach point, not necessarily the device, so that we deliver services to that area of the network that they want. But I don't allow their device to attach natively to my back-end private network. So it is driving a lot of architectural change for us in how we layer our networks and how we allow these how far in do we allow these devices to be. And it's also forcing us to look at how we deliver services to these people differently. So that we can take it to their mobile device and reduce the risk. We're definitely looking and keeping a close eye on where the MDM market is. We use both good technologies, and we have just started doing development work with AirWatch to be able to look at how we utilize their tool, both in our corporately owned device world as well as in a personally owned device operating within our environment. I think in the next 5 years, there's going to be a great deal of evolution in that space for how we deal with this, both from a manufacturer perspective as well as from a vendor perspective for providing tools to help us secure it. But the biggest issue right now is I think for healthcare, is all of these vendors and software that we use every single day to do our business, those are highly proprietary systems. We are heavily dependent on the vendors providing us some type of a mobile conduit, whether that be an application or what to go on those devices to even allow them to interface with that. So there's a catch-up there that's got to occur where those three things are going to come together to create a manageable model for us. But it is driving a lot of change for us, and it's also driving us having to add people with specialties in understanding mobile devices today.
I have one last question.
Have either of you tried to quantify the costs involved with meeting meaningful use, and especially the audit? It sounds like, are there activities that you normally wouldn't have done if meaningful use hadn't been in place? I'm trying to get a sense of, based on the incentives, what's the percentage in terms of compliance costs?
Yeah. For Adventist, we have a lot of financial people that keep a very close eye on, numbers and how we spend dollars and those things. But when we first went through meaningful use, it was amazing how we found we were already going down many of the paths they were already dictating. We were maybe, 5% off the threshold or, something. So for us, it was about us just putting a real sort of focus push to the finish line to get those things implemented, where I think it was very different for a lot of other organizations. But we were already well with CPOE. We had deployed across all of our hospitals. We already had physician orders going in, nursing notes were being done. All of that was already being done in our electronic medical record.
And I think we're similar. There's no way that the meaningful use incentive money offsets what you do to get to that point. In fact, I think that folks who tried to respond to meet the requirements because of that money probably didn't have the culture in their organization to support implementing a CPOE, and the things that's far more difficult from the human perspective than the technological. So we know the money that we receive from the incentive money doesn't even come close to the money we spent to build the systems that we have. Did we spend extra on a few things? Possibly, but as Chris mentioned, the HIPAA security's been around a long time. Now people have just kind of brought it to the forefront again because they're trying to check the box for meaningful use. So all of those things are really more smart business practices, I think, on the risk mitigation than they are really spending money for meaningful use the way we've looked at it.
All right.
Go ahead.
Oh, I just want to say thank you guys very much. I mean, it was a very informative session, and I really enjoyed it. And I think both Ed and Sharon and Chris will be around for our networking reception in an hour or so.
Yes.
Yes.
And so there'll be opportunities for more questions. So right now, we'll get ready for our next session on securing mobile devices, which will actually continue with some of the discussion that Ed and Sharon started. Thank you very much.
Thank you.
Thanks.
Thank you.